Welcome everyone back into Eye.Talk.Tech, where we explore the intersection of eye care and technology. Today's topic, moving beyond trial and error, fitting towards precision, efficiency, and integrated diagnostics. Our guest today is Randy Kojima, a renowned authority on corneal topography and specialty lens design, and he is joining us on behalf of Euclid Vision. Randy, I'm excited to have you here today. How are you doing?
Doing great. How about yourself?
I'm doing wonderfully today. We had to battle through some technical difficulties here, so no microphone, but hopefully we can make up for it here on in. To start off, for decades, kind of a topographer is a topographer, and that's kind of what it is. I want to get your perspective on maybe why that's no longer the case, and what does a specialty practice need to look at in this space here is an opening foray here.
Yeah, it's such a good point. I was thinking back on how corneal topography was really a glorified keratometer, and we essentially just did the photo and then we took the K readings, and that's all we did. And it's kind of funny that we had all these data points, but we really didn't know how to use them. And now today we're using this tool far more than just for K readings. We're understanding 100% of the surface that we're measuring, not just, that 3 millimeter center. We're using the data to understand disease. We're using the data to determine contact lens parameters. There's so many things we're collecting from these instruments now. It's, as you indicate, it's a completely different tool than it was, say, 20 years ago, 10 years ago, even.
Yeah, so I see, kind of the main spots where this utilization is so vital is being myopia, particularly myopia management, right? Scleral lenses and scleral lens design and dry eye. Is there anything in addition to that you would say is a focal point for you?
Ah, boy, you've kind of nailed all the big ones relative to the myopia management aspect of it is really what drives corneal topographer sales. Scleral has really come on as another piece that we're relying so heavily on this technology, and never before has the instrument been used as a tool in dry eye practice. That's very much in the last, 5 to 10 years. We do all kinds of imaging with our topographer to just uh, data collect and diagnose, because the instrument's optics have become so good, not just for understanding shape, but as an imaging tool and just collecting and documenting data that we find. So yeah, as an imaging device, it's really evolved from being only about cornea to being all about anterior segment, from cornea, limbus, sclera, lid margins, flipping lids, and doing mybography. I mean, it's so much more of a tool than, as you indicated, Dr. Christensen, it's not just a corneal topographer anymore.
Sure. And would you say that wide array of different things you can do with a device like the Medmont Meridia Vantage is what differentiates it from those legacy topographers, or is there anything, in addition to that you would highlight?
Yeah, one of those really amazing pieces of the Medmont is the ability to capture topography, but then have the patient change fixation and capture images all over the cornea. So
Mm,
you expand your analysis of corneal shape, not just to the, let's call it, screening image, the single image you get of the center. You're actually stretching your analysis all the way to the limbal borders. And then the Vantage, what it does is it allows you to image both limbus and sclera as well. So you're really stretching your understanding of anterior segment depth, shape, well beyond the corneal borders. I imagine when you went through school, we didn't have that much exposure to the scleral lens side, not like we do today, where, if you took a practitioner from, say, 15 years ago, the scleral wasn't really on the radar of
yep.
the curriculum. But, our students come out of the school today and they're, scleral, they're as comfortable as fitting that as they are any other contact lens. So, having that understanding of what's going on beyond the limbal borders really helps us to make the right decisions. And The Medmont's strength is its ability to capture multiple images or even just single screening images to get that full picture of eye shape.
Yeah, that's really interesting. I didn't realize how far that had come, within the educational system. Randy and I, of course, kind of crossed paths when I was at Pacific, which doesn't seem that long ago to me, but apparently the years are stacking up here. Yeah, the actual physical mapping of the sclera was not something that was focused on even that short time ago. So what do you do with that scleral data? How do you think through this? Now that we have this access to more data here, certainly that allows us to map in more depth how we might want to design a scleral lens. But I just want to talk about, maybe other applications too, but let's start there. You have the data, and how do you conceptualize that?
Yeah, the very first thing that we want from a scleral topographer, that's what you're asking, Dr.
Yep.
Christensen, relative to scleral, that I want to know, is the scleral surface symmetric? Is it toric or is it asymmetric? And most of our diagnostic sets would be symmetric or toric landing. And in fact, the company I work with, Euclid and the Visionary Group, their trial set has both symmetric and toric landing trials. So let's make the right decision to start. Which trial lens should I be pulling out? Should I be pulling out the one that has equal elevation all the way around or two meridians of depth? Let's choose the right one to start with. So that's the very first piece that we need to determine. The second is the depth. What height of contact lens do we need? Because if I take a diagnostic lens out of the set and I clean it, I condition it, I take that time to get it ready to put on eye, and then we place it on eye and it has inappropriate depth, or we haven't used our technology appropriately to determine the right height of contact lens, then I've just wasted a time. I've inconvenienced the patient to a degree. So, choosing that right lens is really important. The third component, and one that is really so techy, is the ability to construct a lens by the topographical data. So forgetting about diagnostic lenses and just purely taking all that digital data, importing it into a software that can construct the lens in 3D. And that's really the future of scleral lenses. If we started with molding eyes, pardon me, taking molds of eyes and then determining the initial parameters of lens. That would have been generation one, and then generation two would be using diagnostic sets that were ideally designed for patients. And then the third, the most modern component, is utterly topography-derived scleral lenses.
And how much would you speculate that a strictly empirical design process can improve efficiency?
Yeah, the Visionary Group, part of the Euclid Vision Group, they estimate that it's well into the 90% range of
Wow.
first fit success. So it's incredibly high. Now, that number to me, it's impressive enough at 90 something percent, but it's the fact that we use the topography derived scleral lenses on the worst of eyes, on the more normal, more symmetric and toric shapes. You're just using your diagnostic set for those. So these are patients that are the worst. They're the worst of the worst. And, Dr. Christensen, as you know from Pacific University, our contact lens service, it gets referred all the worst of the worst, and those are the patients that we fit. And when we are struggling with a symmetric or toric landing scleral lens, we go straight to topography derived because it creates that perfect glove fit in every meridian, and it really improves the outcomes for patients. The physiologic response is we're not having the agitation in one area or the other, discomfort, centration, visual quality, all the things that we want for the patient, we get out of a topography-derived scleral. So it's really an exciting time relative to what we can do with the technology, mapping the eye surface, what the lab can do with their lays and their ability to be micron accurate, all the way around the lens throughout the entire elevation and every radial. It's really an impressive time in contact lenses in general, Scleral, Ortho-K, custom soft, you name it. What area are we not using technology to drive, truly custom contact lenses?
Yeah, I kind of like the history. We got the technology on one side. I kind of like reviewing the history a little bit too. We of course had kind of the contact lens museum that Pat Caroline was working on at Pacific there, and my dad's an optometrist as well, and so kind of picking his brain. And one things that I've heard him mention that I think is cool is the history of scleral lenses in the early 20th century here, and kind of becoming an antique at one point, and then to see the resurgence here and meshing with technology is kind of a cool full circle moment for sure.
It's so true. It was our first contact lens, right?
Yep.
Our first contact lens was a scleral lens. It wasn't a corneal contact of any sort. It wasn't, certainly wasn't soft. That was way after
Yeah.
everything that was, rigid, hard, all that kind of stuff, glass. So yeah,
Yep.
it's really impressive how much the industry's changed within, basically one optometrist's career. One we could take your father's generation, and a lot has happened in that time.
Certainly. And is there any other portion of your kind of fitting procedure personally that leverages technology? So, one thing I find myself using frequently is an anterior segment OCT. Is there anything else that you would touch on that helps your workflow?
Relative to corneal topography or outside of corneal topography?
Just with the whole corneal, or excuse me, scleral fitting process.
Yeah, definitely the OCT would be that tool
Yeah.
that's a love to have relative to contact lens fitting in general, not just scleral. As an example, understanding discomfort by taking those cross-sectional OCT images, you can see the contour of the lens edge. In the scleral, you can see, does it dive into the surface? Is it parallel to the surface? Are we edge lifting? Things that might be trickier to pick out through the slit lamp or even using the imaging on the Meridia, the Medmont. Using OCT is one of those very cool tools that really tells us stuff that we can't see otherwise.
Yeah, I totally agree. I find myself, catching my interpretation of what blanching or something looks like with the vessels is sometimes not in alignment with what you can detect on the OCT. So the vantage point of being able to see kind of in a direct aspect from the profile and so forth of where that landing zone is, that's one thing that stands out to me for sure. But you'd
I mean,
agree
to
there's
play a
there's a
supporting
difference
role.
between, yeah, what was that, Randy?
Sorry, I was just going to say, I think, what you're describing is that tool used in a supporting role to all the other tools that you're using in your clinic to best diagnose for the patient. And, we're talking about specialty lenses for the most challenging conditions. Why not have all this tech being used to help us make the right decision? So I think you're absolutely right to, be looking beyond our standard slit lamp to, best serve the process of optimizing fit.
I want to get into the topography utilization and use case for Ortho-K, of course, too. But just kind of a speculative question, with some of the AI algorithms and modeling and so forth that's arising to determine maybe what the progression of the myopic state might look like for a patient. Do you think there's any data that could be leveraged from that scleral profile that might tell us what the progression of the eyeball growth itself would look like? Is that something that you're aware of at all?
Not relative to the sclera, but you might be onto something that it's kind of early in our understanding of mapping sclera and these large cohorts of patients to be able to predict what's next. I mean, certainly we're learning a lot from corneal topography
Yeah.
and being able to predict directions we should take in lenses, but in myopia management, what would be the right signal? Have we produced not just good Ortho-K, but have we also produced an ideal myopia control Ortho-K? So there's those kind of tools. But man, I love where you're going on this to, better map the sclera and try to make predictions of, what direction is this eye going? We just don't have a lot of data on this,
Yep. Yep.
especially in
So
young kids too. I mean, you're really onto something because most of our scleral study is on patients who would be fit with scleral lenses or just to understand general eye shape, and it's all adults. We don't have anything on understanding or seeing the progression in young eyes.
yeah, we've
You've
seen
given us a study, Dr. Christensen. I can't wait to talk to Pat Caroline about this. He's going to love it.
we'll dive into that next time. That'll be a follow-up episode. But we've seen kind of the screening in eye clinics transfer. We're going to doing macular OCT screenings as part of a general eye health exam. And I just wonder as we gather more data there, certainly we find things that maybe we weren't aware of how the frequency of different disease states and so forth. But having a map of the front of the eye, might be something that long term could be leveraged. Now, in an area where we do have more of an understanding already, certainly is the topographical use case and how we can utilize that data for both optimizing the Ortho-K fit, but looking at progression likelihood and mapping that out, and also saying, hey, are we doing a good job with this fit to mitigate that progression as well? Could you talk a little bit about how the Vantage might be different in that regard?
Yeah, one of the things that we at Pacific have been very focused on, and Dr. Christensen, maybe this was an area you were exposed to when you were there, because it goes way back. Our mentor for both of us, Patrick Caroline, he's a very curious fellow, and he very early on said, let's not just look at whether these lenses are centering, let's look at the power profile across the lens surface and try to better understand this. Is it optimized for an adult? And does an adult require the same, let's call it power profile, eye shape that the child might require in myopia control? And so that research from a good 15 years ago, at least, has led to us looking very closely at the kind of pre versus post shape that you create. And what I mean by that is, we're not just looking at whether the apical change creates the RX change. We're looking at whether the shape across the pupillary zone is creating the right signal for the age of patient. So as an adult, or as an example, for us as adults, we want the least aberrations possible. Refractive surgery has shown us the more aberrations, the more likely the patient is going to have visual problems. But for the kids, it's a completely different story. For the kids, we want to amp up all those aberrations and defocus because that's what slows down eye growth. So sorry, I maybe took a bit of a roundabout way to get to it, but this is what we're doing with the topographer today with the Meridia is to study that cross section of power that exists within the pupil. And essentially, the higher the defocus, the better the myopia control. The more decentered the optics are, the more, let's call it, coma that you create, the better the myopia control. So, there was a time when all we looked at in Ortho-K was whether the lens centered well. But today we're looking at whether it centers and whether it's creating these aberrations that we want for kids. And then for adults, we're obviously trying to minimize those aberrations. And it's about 15% that orthokeratologists would fit adult patients. So 85% are myopia control in Ortho-K and approximately 15% for our adults. So yeah, we don't want to forget about them either. And we should
Sure.
have two different approaches for those two different ages of patients and those two different optic requirements that they both have. Because that power profile, that post-Ortho-K shape that you want, very individualistic between adults and kids.
And would you say it's individualistic between various kids as well? Like, is there a limit to how close you can push that defocus zone towards the parafoveal area? We tend to get a stronger response as we get closer to the macula and parafoveal area. Is there a limit to that, and does that vary between kids in your experience?
Yeah, it's such a good point. It is really important that we recognize fast and slow progressors, and the fast progressors, the ones that their axial length is changing very early and very aggressively. Those are the patients that we want to maximize that defocus signal. So we're looking at the higher end of the chart of what we want to create, and what I mean by that is small treatment zone. We want the amount of plus power. We want the minus to plus distribution to be immediate and be very significant, a high magnitude of that change. So those kind of indicators we're getting from the instrument would tell us for those fast progressors, this is what we want to do. Now, a simple way that a practitioner could understand is as soon as we've pushed too much, the patient is probably going to have poor quality of VA. They won't have that real crispness that we're hoping and expecting. And once you've reached that limit, just to back off slightly. Either make the optic zone slightly larger, make the asphericity of the lens slightly lower. So that would be the upper limit. If the patient was struggling with that kind of quality of vision, then we know that we've pushed too much defocus. In the same way that we do with multifocal soft lenses, right? We put patients into 250 ad soft multifocals, and if their aberrations are high, we back it off to a +2, right?
Absolutely. Well, and one other point on the myopia management front, I'd be curious your perspective on too. We had big news on Friday regarding FDA clearance of a new spectacle lens option, and I think that's going to be a very interesting space. Does topography give us any way of still measuring some information that might indicate what sort of progression profile someone might have, but we might not even utilize a contact lens? Do you see that as a possibility in the future here?
Yeah, absolutely. I think there are patients that their eye shape is such that fitting a orthokeratology lens is going to be a real challenge. Some patients that would steer you toward a contact lens over glasses. So yeah, definitely there's things that we can do diagnostically that you would evaluate your baseline topography for these patients and choose the right path. For instance, if you see a highly regular eye shape, then you have lots of options. You could go the glasses route. You could go soft lens route. If you're seeing a little more asymmetry, then maybe molding the central surface, smoothing it out a little more in Ortho-K might make some sense. But if, for instance, you saw a highly displaced apex, then you know that it's going to be hard to center that orthokeratology lens based on the eye shape. So you're using metrics in the instrument to try to help guide those decisions. So you're making the right decision to start with.
Sure. Well, and then the third point of primacy for topography, dry eye, right? Could you walk us through, maybe how you would take a patient example or a clinical example of what an intake visit would be like and how topography in a device, like the Meridia Vantage would fit into that workflow?
Yeah, what is amazing to me about the instrument, forgive me for sounding very, commercially oriented on this, but I really geek out about the optics. I love to be able to capture images and video of the contact lenses on eye for documentation purposes. And what Medmont, the engineers have done a really incredible job of is packing this high resolution camera into this tiny center of the cone that captures wicked good images of the lid margin, the field of view, the size of view. The depth of view, sorry, is really impressive. So yeah, what you basically can do is have your technician do the pretest of lid margin, of ocular surface whiteness. You can have them take both the eyelashes themselves, or if you feel comfortable with them flipping lids. These are some of the things that they can do and provide you with that imaging before you've even seen the patient. So it's ready for you to analyze and diagnose and communicate to the patient. So I think that's a really powerful thing, that the way the imaging works, a technician could do much of the imaging that you need on the front end to provide that, diagnostic, both documentation and analysis in the exam room. So you're basically a little more efficient, right?
Sure, sure. Well, and there's a lot to bite off with the different various use cases, and you're not going to step in and do everything all at once in all likelihood. But in terms of building on success and getting efficient with a device like this, what is kind of the mindset you would encourage a clinician to adopt to implement technology like this successfully?
I think it comes down to one really simple thing: the technician. If
Mm,
you can utilize your technician to do much of the work, the instrument itself was created so its ease of use is, as accessible to everybody as possible. So just teaching somebody to focus where you want them to focus. The instrument just takes such beautiful images. It has two light sources on either side. So whether it's white light, cobalt for fluorescene, or infrared for meibography capture, the way it illuminates the surface makes it pretty easy for a relatively inexperienced person with, let's say, a microscope to use. So they're able to take both the images and video, and to help you to be more efficient by leaning on the technician. You're really going to make this instrument sing for you, where you could focus in the exam room on the things that an optometrist really should, getting the patient behind the slit lamp, the phoropter exam and such, and then you've got all this imaging to lean on and review with the patient. It's already been done. You had that done in pretest, and now you can take the big picture of all that you've collected, both from the slit lamp, from the phoropter, and your diagnostic imaging. And your technician has really helped you along the way to get to that endpoint, and to be efficient in the exam.
certainly. Well, and to your point, just imaging in general lends itself to having a conversation and being able to explain that to the patient. But with the imaging that's derived specifically from this device, do you feel like there's pretty good explainability and patients are grasping what it is that you're looking at?
Yeah, absolutely. Yeah, I'll speak a little bit more from the university perspective, but
Sure.
the imaging capabilities of this tool is so good that we don't roll the slit lamp into lab anymore. We use the Medmont, and the reason is, we take our computer connected to the Medmont, punch in the HDMI cord to it. It's up on the big screen, and we get better illumination and better imaging than we do with any slit lamp that we might roll in. Now, I'm not saying an imaging device replaces what a slit lamp does. It definitely does not. But for the type of anterior segment assessment that we need, this tool is so beautiful in the way it illuminates, the depth of field that it has, its ability to show you images in stills, video, or live, is just so impressive. The camera on this thing is just, as I said before, wicked good.
Wicked good. Well, that's a great tagline. Randy, thank you so much for sharing your insights today. Always fun to pick your brain here as well. Getting a little clinical perspective and this is a really exciting device.
Pleasure.
So, to our listeners, I would just like to say, what would you guys like to see covered in the future? We would love to hear your thoughts in the comments. You can learn more about Medmont and the Meridia Vantage by visiting Euclid's website, which we will be sure to include down below in the description as well. And finally, if you found this valuable, please like, subscribe, share it with your colleagues to help everyone stay ahead of the curve in eye care technology. Randy, thanks again. I hope you have a wonderful day, and we'll see y'all next time.